Good morning, everyone, and welcome to the Project Echo's West Vic PHN Hub. And today is the 25th of October 2022, and this is the third series of this Echo network, and it's our first session for this series. So I'd like to welcome you all this morning, and this session is entitled Assessment of Mental Health for People with an Intellectual Disability, and it's the first of 4 sessions where we explore mental health in people with an intellectual disability. So I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming in from today. And I'd like to pay our respects both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support the self-determination of First Nations peoples and organisations, and we'll work together on closing the gap. So my name is Dr. Robert Ward, and I'm a full-time GP in Geelong. I'm also the father of a 25-year-old young man with an intellectual disability who lives at home with us and will always be dependent on family, society to care for him and to make sure he is safe and happy throughout his life. So I'm pretty keen to see that society gets this right, and that those people who are in charge of creating the system that will ultimately look after him create a system that best serves his purpose and all those others in our community with intellectual disability. So this Echo series is brought to you by the West Vic PHN in response to the federal government's release last year of the National Roadmap for Improving the Health of People with an Intellectual Disability. The aim is to improve the understanding and skills of those working in primary healthcare so they can better care for this diverse population of people. For those who have joined us in the first 2 series, will know that we've explored topics like reasonable adjustments, early development, communication, and regular health screening, and that we've been joined by experts in their fields where we can share and explore our knowledge and understanding. In this next series of 4 Echo sessions, we're going to explore the issues surrounding the all too common occurrence of when mental health conditions coincide with intellectual disability. How do we identify this, and how do we assist our patients, their families, and their carers? So I'd just like to do some introductions, and I might put up the etiquette slide, please. So with these Zoom sessions, I'd just like to remind everyone, if they can, to have their videos on, turn your audio to mute, except when you're speaking, and to make sure that you're labelled properly so we know who's there and how we can introduce ourselves. We'll do a quick introduction to start with, so just be ready with that if you're able to. Please feel free to use the chat function if you want to ask questions or add some more details. The PHN Echo staff always are checking on the chat, and they'll also put some information in there to link you to some of the things that we can talk about today. We will be having some time for discussions at the end, so we can certainly do that. Just a quick note around the privacy policy. There'll be a didactic talk which will be recorded, but we won't be recording when we do any case presentations. And so if during your talk, but we always remember just to remain confidential and respectful for all our participants and our clients and our patients, as we all should. So I'd like just to introduce everyone today and see who's around. Firstly, I'd just like to introduce everyone to Chad Bennett. Chad works for St Vincent's Hospital with their dual disability service, and he'll be our didactic presenter today. We've got Dr. Jane Tracy on our panel today. Jane was a former director of the Centre for, I can never remember how to say it, Jane, Centre for
Developmental Disability Health.
There we go, from Monash, and Jane's been with us for these Echo sessions for the time. So we've got Whitney's there and Gemma there from the Echo project, and they help put all this together, which is fantastic. We've got Kerry down there. Hi, Kerry. She's from the Spider project, who's helping coordinate this. And I just if I can go through and just call people out, and you can introduce yourself. So Fiona, hi, welcome.
Thank you. I'm happy to be here. So yeah, I'm a behaviour support practitioner with Clear Thinking Mental Health Group. So basically, I work with individuals with a disability and their families and their care teams to develop individual plans to address behaviours of concern and help to identify their needs and how we can best transform those behaviours to be more functional.
Great, thank you. Thanks, Fiona. And John Newman's there. Hi, John.
Hey, Rob, everyone. I'm a general practitioner in Geelong West.
Thank you. And Vicky?
Hi, I'm with the Tweddle Hopes program, and we're an early parenting program. And at present, I work with families with an ID.
Thank you so much. Got Zach, you're there walking. You able to talk, Zach?
Yes, hi everyone. Thanks for having me. I'm Zach from GNU, Senior Behaviour Support Practitioner here.
Great, thank you. Welcome. Evelyn. Hi, Evelyn.
Sorry, Robert. Hi, everyone. My name is Evelyn. I work at the Royal Children's, transitioning patients from paediatric to adult care, and am fortunate to be part of the SPIDER team working with Rob and others to improve the lives of people with intellectual disability. Thank you.
Well, thanks, Evelyn, and welcome. Amy, and Amy's going to be a case presenter today. So, Amy, do you want to just introduce yourself if you're able to?
Yeah, hi everyone. Sorry, my camera's not working today. I'm a GP in Ballarat and a GP editor with Health Pathways for Western Victoria.
Thank you. And Amy will have a case study for us today. And Nicole's also with the SPIDER team. Hi, Nicole, welcome.
Good morning. How are you?
Good. I think that's probably it for everyone. So hopefully we'll have a good chat about everything. So our agenda today, we're going to have a didactic talk from Chad, who's the clinical director and consultant psychiatrist with the Victorian Dual Disability Service based at St Vincent Hospital in Melbourne. We've got panel members to help with that discussion is Jane Tracy. And we did have another panel member, but I don't know, Whitney, no sign yet. Oh, if he pops into
I don't think he's here yet. He might be joining us late. But
if he pops in, we will introduce him to everyone, and we can use him, and then we'll get to our case presentation later on. So I'd just like to remind people about the case presentations. I think we've got that slide there. The Echo series is built around people bringing cases to a group and having a chat about them and with each other and with specialists. So if you do have any cases, please feel free to either go to the link or scan on the QR code there. Especially these series of 4 sessions on mental health. It's probably, we might think about a few in the few sessions and want to put a few for the next sessions to discuss, especially if there's any that are difficult in our practices. Just a quick reminder about professional development. There are some opportunities to get some points here, so please sort of just make sure please make sure that you log on to that if you need to. And you can also go to the workforce development team via the website there. There's also a survey, so if people are able to do that survey, would be fantastic, and I think there's a link to it in the chat as well, if you don't get the QR code. So if we could just talk about the learning outcomes for the series. So we're going to try to recall the terminology used in describing intellectual disability and developmental disabilities, identify solutions to support primary health and professionals deliver high quality health care tailored to the individual needs, assess disparities between the health inadequacies in our health system for people with intellectual disability. We need to know about the United Nations Convention for Rights of a person with a disability, and to summarise and implement reasonable adjustments in our practice. So that brings us to our presentation today. So I'd like to introduce Chad Bennett, and I don't know if any of you were at the webinar the other night, but Chad gave a fantastic talk, and I've heard Chad talk a number of times about the interface with intellectual disability and the mental health system. So his presentation today is about that. So Chad, I'd like to hand over to you.
Thanks. So I'm going to talk a bit about assessment of mental health in people with intellectual disability. And just a word of warning, I'm currently refereeing a match between a new cat that we've got and our dog that has taken a very strong dislike to the cat. And also the cat seems to like walking across the computer, which is kind of warm. So, am I able to get the PowerPoint presentation up? Yeah, okay. So I think it was Whitney who sent me something about learning objectives. So I thought we haven't got long actually, but I think kind of in a nutshell, if you want to think about the mental health and intellectual disability, what intellectual disability does, it complicates it makes it more, the whole process of assessing whether someone's got a mental health problem more difficult. And you end up working in what I call the grey zone, where you're much less sure about actually what's going on and what diagnosis you're working with. And so you're working with higher levels of uncertainty. And these are the kind of quick learning objectives I came up with for the assessment today. And if we go to the next slide, thank you. And I guess one of the key points is that people with intellectual disability experience the same range of mental disorders as the normal population. So we see psychosis, we see depression, we see anxiety disorders, but they also experience what I call additional kind of mental health problems. And one in particular is autism. So autism occurs at much higher rates in this population than the normal population. And then the other thing that I'm also describing as a mental health problem is behavior disorders. And the reason I describe that as a mental health problem is that people with behavior disorders require some sort of management and treatment to try and ameliorate the problems with the behavior. And often these involve the same kind of psychiatric technologies that you'd be using in the normal population. So they're often on medication, they're often receiving some kind of psychological input, usually in the form of behavior therapy. And you're having to work around them in terms of their environment and the kind of things that they're able to access. So, there we go. So as well as having additional mental disorders, and this is where it gets a bit complicated because it depends on how you ask the question and what kind of mental disorders you look at. But certainly if you just look at the standard range of mental disorders, they've still got an increased prevalence of mental health problems. And this includes things like depression, anxiety, psychosis. And the reason for the increased prevalence is thought to be that they have the same risk factors as the normal population, but they occur at higher rates. So if you think about things like epilepsy, for example, epilepsy is associated with high rates of depression in the normal population. Epilepsy, we see at a higher incidence or prevalence in people with intellectual disability. So they have higher rates of biological risk factors. They have less, they're often subject to trauma. They often have difficulties with developing psychological ways of dealing with the stress in their lives. And they don't have access to the same opportunities that other people have. So they may be less able to ameliorate the kind of problems that they're experiencing. And so these factors seem to lead to increased rates of mental health problems. And in addition to that, they find it difficult to access mental health services. And these are for reasons like difficulties in getting to services, difficulties in recognizing what's a symptom, in what they might be able to get help with, professionals not being trained in working with people with intellectual disability, the service system not being well set up to manage people with these kind of problems. And then at a systemic kind of level, we find, for example, that inpatients won't admit people because people with intellectual disability don't necessarily fit into their programs because of their cognitive level. So they won't be able to participate in group discussions, etc. So there's a range of barriers to getting the higher rates of mental health needs met. Next slide, thank you. But if you're thinking about assessment, the principles of, and I'm talking about mental health specifically, but the principles are the same. It's just that they have to be modified to account for the presence of the intellectual disability. And what we're trying to do is kind of like identify particular symptoms, when they started, what exacerbates them, what makes them better, and then to pop these into the different diagnostic groups that we're pretty familiar with, and we use the standard recipe book of a psychiatrist, which is DSM-5 currently. The rule of thumb is that you can use DSM-5 for most people with a mild intellectual disability, so down to about an IQ of about 50, although people with autism may have specific communication deficits and difficulties in recognizing, for example, things like emotions that make it difficult to use your standard classification systems. And we're trying to determine the etiology and look for treatment and prognosis. And we adopt very much the same kind of methods that you would use for the normal population. We'd usually see the client unless there was particular reasons why you couldn't, such as risk issues. One of the interesting things is we did a little study looking at how we assess people, and we found that on average, so your standard psychiatric assessments takes an hour, and by the end of that, you should have a fairly comprehensive idea of what your diagnosis and what your initial treatment kind of strategies would be. What we find is that when we're doing this for people with intellectual disability, it can take up to 20 hours, and on average it takes us 15 hours. So it takes a lot longer to get the information that you need to be able to come to an opinion as to what might be wrong with someone. We spend a lot more time speaking to informants and looking at past records than we do necessarily working with the individual, who's often unable to give us the level of detail that we would need to make a diagnosis. I think one of the advantages we have in the Victorian Dual Disability Service is we have the luxury of time. So we're able to take that time to do that more thorough, comprehensive kind of assessment. And in doing the assessment, you have to modify the way that you would do it. And this is going to depend a bit on the severity of the cognitive impairments and the support systems around that kind of person. But the broad framework is the same. Next slide, please. There are some special considerations, and we'll go over these kind of one by one. And these are things that I suppose are somewhat different in this population that you need to at least be aware of. So next slide, thank you. So one of the things that's becoming more of an issue is about people's capacity to consent and ensuring that we are actually getting informed consent. So consent is about the person's ability to understand the information that's presented to them in relation to a particular treatment option and what that means for them. And to have some idea of some of the potential outcomes. And they also need to be able to communicate their decision. They obviously can change their decision as time goes on, and they need to be free of coercion, which can be a bit of a tricky one because often the people around them want them treated, although they might not necessarily want them the treatment. It's interesting that if you look at this population, there's very high rates of antipsychotic medication prescription. And what we find in people with psychotic illnesses, most of them don't take their medication, whereas this population is actually the only group that does seem to take the medication that they're prescribed. And that's usually because someone else is giving them the medication. There's a couple of things to be aware of, though. So in the Medical Treatment and Planning Act, there's actually quite significant penalties that apply if you haven't documented who is consenting to treatment. And this is particularly for significant treatment, and this includes all psychotropic medication as well as psychological therapies in relation to trying to change someone's behavior. If someone is unable to consent, you've got a couple of options. Under the Guardianship and Administration Act, there's the kind of default position that often the next of kin, and it's a bit of a scary one, this one, but apparently the person who can make decisions on our behalf is actually our spouse. So I think the message is always be good to your spouse, because they could make decisions for you in life-threatening circumstances. And if you've got any concerns, they're more than happy to take phone calls and help work through. It's interesting in this population, although they often can't consent and often being treated for mental health problems, the Mental Health Act doesn't apply or isn't applied. There's been a recent change in Tasmania where they've actually made a determination that anyone who can't consent and is receiving some kind of psychological or psychiatric treatment needs to be done under the Mental Health Act, which has thrown the whole system into chaos, because there's probably about 1,000 people in the whole of Tasmania that suddenly need to be treated as involuntary patients. But anyway, you need to think about capacity, need to document who's consenting to any treatment that you're providing. Next slide, thank you. Then it's thinking about that in where you're going to see someone and how you're going to manage that. And one of the things we try very much to do is actually to see people in their usual environments, because a lot of people with intellectual disability find it quite stressful going to medical appointments and have had quite negative experiences of medical appointments over the year. And so it's about kind of trying to think where's going to be the best place to see someone. What kind of observations am I going to take? And the other problem that we often run into is every man and his dog wants to come to the assessment, and so we'll end up with about 5 people going to see this poor person who's not feeling very well and finds it difficult to communicate. And so it's often about trying to limit the number of people that might be present in any particular assessment. As I said before, normally we would see people for an hour as a psychiatrist, but often people with intellectual disability can't tolerate that amount of time. And so it might be breaking it down into shorter 10-minute sessions and doing that over several weeks rather than doing it in one hit, and avoiding having to that temptation to make a decision and come to a quick judgment. A lot of people with autism find it difficult in crowded environments or high stimulus environments with lots of noise, bright lights, fluorescent lights, music, people moving around. And so if we were seeing someone in a clinic, we would try and make that the first appointment of the day so that they can come in and get out, and we can stick to the time frames that we've said that we'll be seeing the person in, as well as thinking about, you know, how are they going to get there and who's going to be coming with them. Often what we find is that they'll employ a carer for the day to bring them to an appointment, and the carer has never met the person before, and no one's able to tell us what's going on. So it's important to set up that initial clinical encounter so that you're geared for success. Next slide, please. It's always worth asking about how the person communicates, whether they use any communication aids. So some people will use things like Compic or iPads or some form of technology to be able to communicate, whether they have any problems with hearing or dysarthria, that you may need someone who's familiar with the person, who's able to translate what they're saying. I always kind of start off with asking quite simple questions like age, name, date of birth, address, and you build up in complexity to try and get a sense of what that person is going to be able to tell you in relation to their history. Sometimes in people with more severe disability, it might just be a question of trying to engage with them, rolling a ball around, seeing what their level of interaction is, what their non-verbal skills are, trying to get them to think about what their mood is in terms of smiley faces or sad faces or normal faces, just to get a sense of whether they can report on their moods, as well as trying to kind of be aware of any sensory hypersensitivities or impairments that the person might have. Next slide, thank you. I think a key is to get as much information as you can, and we often spend our time trawling for the right people who can give us, I guess, what I call high quality information. And what we often find, it's often the managers who want to give us information, when it's usually actually the people working most closely with that particular individual who's able to give us the most useful kind of information. The other kind of issue you run into is people have quite different views on what is the problem. And normally when we see a patient, we're dealing with their problems. And I think one of the interesting things about working with this population is actually usually not the person himself. In fact, I think we've been in operation for about 20 years now. And I think we've only had about 5 people actually refer themselves. So it's always someone else who's referring this person because either they've got a problem with them or they think that that person has a problem. And then you might find that the carers have very different views on what the problem is from a family member, as well as the individual themselves. And so one of the things you're having to do is trying to kind of bring all those different views together, and that can be quite a lot of work in itself. A key question within this is kind of, well, what's the person's usual level of function? And it's about trying to establish what that person's developmental level is, but also kind of like, if they're unwell, what are they no longer able to do? And it gives you a target to aim at in terms of trying to get back to where the person was before. If someone's got a long history of impaired function, it may be more of a long-term problem rather than the onset of an acute illness. And usually, again, what we find is that the people we see have usually been assessed to death. The problem is usually in implementation of any recommendations that are made. And we often get a lot of information from accessing previous assessments that have been done by other professionals that happen to have seen that person. There are also a number of assessment tools that can be used, and these can be useful to kind of establish a baseline, give you a bit of an idea of about what the diagnostic possibilities might be. But they generally can't be used to make a diagnosis. And some people find these kind of tools useful. I tend to prefer to adopt a clinical approach, but a couple of my colleagues use these with some of their assessments that are more complicated. Next slide, thank you. There's some issues in relation to assessing people with intellectual disability that complicate the assessment, and we call these pathoplastic factors, and I'll quickly run over these. So one of the common ones, and we see this in a lot of medicine, is that if someone has an existing diagnosis, we tend to attribute all the symptoms and signs to that known diagnosis rather than thinking about other diagnoses, and this is called diagnostic overshadowing. Intellectual distortion is related to people's difficulty that they might have in communicating fine-grained descriptions of how they're feeling and what makes them feeling in a particular way, and to be able to tell you about their experiences. Psychosocial masking is about they don't have the same range of experiences and reference points that the general population have. And so when they're unwell, a grandiose delusion might be, for example, driving the bus, because that's the breadth of their experience, where for you and I, it might be being God or you know, being Prime Minister, whatever it might be. So it's about their psychopathology can only be manifest in the range of their experiences. Next slide, thank you. A lot of people with intellectual disability are very used to being taken to appointments, and often will just give the right answer to try and please people, or to try and get out of there because they don't like it, so they'll answer yes the whole time. It can take some work to try and gain their trust so that you can then get into the actual psychopathology. You see things like people are described as hallucinating because they talk to themselves, but that actually might be quite appropriate for their developmental level. And then you see, for example, 18-year-old men with a very high sex drive, but who've got a low IQ, masturbating in public. And that can get mistaken, for example, manic behavior, rather than thinking about it in a developmental context and about their level of understanding for their behavior. And problems can come and go, particularly in different settings. And that's why we find it useful whenever we can to see people in their own environment. Next slide, thank you. One of the things, and I guess I never really understood this until I started doing this job, it's actually really important to get a developmental history, because this gives you a sense of where the person is normally at. You need to get a developmental history really to make a diagnosis of ADHD and ASD, both of which are common comorbidities in this population. And it's also about trying to establish, well, what's this person's normal pattern of function compared to where they are now? What might be a symptom of an illness opposed to their long-standing patterns of behavior and skills that's part of their developmental picture. And understanding this can then make it less likely that you're going to make the mistake of diagnostic overshadowing. And it can also help clarify, particularly if you're able to develop an understanding of the etiology of the what's caused the intellectual disability. In some cases, that can help explain the problem behavior. So, for example, someone with Fragile X syndrome are likely to have autistic traits and high rates of anxiety. Someone with Prader-Willi often have problems with overeating. So it can help understand the problems that the person's presenting with. And it helps you then develop appropriate interventions. So someone who's nonverbal, it's not going to be appropriate to try and engage them in trauma counselling or any kind of verbal kind of approach to managing the problems that they're presenting with. Next slide, thank you. Always important to do a physical assessment, and we would usually ask that someone has a very thorough physical assessment before we undertake a mental health assessment. People with intellectual disability have high rates of unidentified medical problems, and those that cause pain that they may not have reported are particularly associated with behavior problems. One of the really difficult ones is getting people's dental health checked out. And young men in particular can present with aggressive behavior. And one of the things that's often missed is problems with wisdom teeth, for example. Next slide, thank you. This is a kind of interesting one. So when we, in psychiatry, we didn't really know what we were doing, and I'm not sure we still know what we're doing. But anyway, we decided to make it reliably not knowing what we're doing. And so we developed DSM and ICD very much based on research criteria, with the idea of improving the reliability of our diagnosis. Unfortunately, all the research that was based to create the different diagnostic categories excluded people with intellectual disability because they aren't able to consent. So although you can use these kind of classification systems, they weren't really developed for people with intellectual disability. And there are a couple of other classification systems that really do look at how you might think about mental health in these kind of populations, but they're not widely used. But these are ICD-10 LD, and then there's a DSM-ID version. But once you get down to a lower IQ, you have to move into a different way of thinking about what are the potential diagnoses. So you, for example, you can't diagnose schizophrenia using DSM-5 in someone who's nonverbal, because they can't experience or they can't report on the hallucinations and delusions that are required to make that diagnosis. And it's actually not clear how schizophrenia might present in this kind of population, or whether you need a certain level of intellectual development to develop certain illnesses. So one of the interesting things is you very, very rarely see psychotic illnesses in children. And there's this kind of thought that you actually need to achieve a certain developmental level to develop certain mental illnesses. And so there's a number of classification problems in relation to how we think about mental illness in this population. And some of the concepts that we use for the normal population may not necessarily be applicable to people with intellectual disability. But one of the things we often get is, you know, someone who's nonverbal who's been diagnosed with schizophrenia, and we automatically think, well, that can't happen because well, they can, but you're not using DSM-5 criteria if you're applying that kind of concept to a diagnosis of schizophrenia in someone who's non-verbal. Next slide, thank you. Oh, I didn't know that this was going to happen. There we go. So when you're seeing, this is kind of like what we were trained in basic psychiatry. It's kind of like doing things like you avoid kind of like leading questions like, are you feeling depressed? So it's, you know, like if you lead them with depression, then people are likely to identify that as a problem, and they're then likely to report it. And it's even more important in this population to try and use the principles of good interviewing, and keep language simple, allow time. So sometimes it might take people a bit of time to process the question, whereas we're often in a bit of a rush and we might ask several questions at the same time, like, are you eating and sleeping okay? So that's 2 questions in one. And actually kind of the way that people might want to respond to those questions might take a bit of time for them to work out what their answer is. So it's about, I suppose, giving time, being aware of the difficulties that people might have in answering questions. And then there's going to always be this point where people can't answer the questions of that level of complexity that you want. And it's about recognizing when you need to move to other ways of getting that information. And sometimes you do need to drill down to sort of like, are you happy or sad? And when you do that, it's about trying to ask that same question in different ways, or even back to, are you happy or sad? And they might say sad, and then you ask, are you sad or happy? And then they might say happy. And they're just picking up on that last word in your sentence. And you're trying to get a sense of how valid is their answer in response to your questions. And asking them for examples and what makes you happy, what makes you sad, what's it like when you feel happy, what's it like when you feel sad, rather than assuming that the fact that they've reported that means that they know what they're saying. Next slide, thank you. So these are, I think, all fairly self-evident, and often one of the things we'll try and do is kind of like get someone to talk about their last birthday or their last Christmas and what things were like then, to get a sense of whether people can report things in a historical, time relevant kind of way. And with some people, you can just work in the here and now, and they can't give you really that kind of longitudinal history, and that's where you start to rely more on collateral history. Next slide, thank you. The mental state, I guess, is the psychiatrist's equivalent of the physical examination. And we use the same format, although it may have to be modified. So, as I was saying, someone with more severe levels of intellectual disability, they may not be able to report on what they're thinking and how they're feeling. But you can always observe people. You can always look at how they're interacting with you. You can look at their physical appearance. You look at their non-verbal communication. You get a sense whether people, you know, I mean, if someone's looking sad and unhappy, or in pain, and that can be a bit of a guide, although some people with autism are not very good at expressing those kind of feelings and emotions. And so sometimes, again, you're relying on someone who might know that person well to interpret that kind of things for you. Next slide, thank you. And so people with the more severe levels of disability, you're more limited to that observational mental state and their ability to engage. Next slide, thank you. So in summary, it's essentially the standard format of history and mental state examination that we use in psychiatry, but the way we go about it has to be modified, and the mental states may be modified. We try and understand why someone's presenting in a particular way using a kind of bias. So in psychiatry, we talk about a biopsychosocial framework. So it's thinking about the different factors in those kind of domains that might be contributing to someone's presentation. And to that, we really add the developmental issues. So thinking about what developmental level has that person got, and thinking about additional neurodevelopmental disorders like ADHD and autism. And you have to adapt your assessment process according to that person's abilities. And as I said at the start, we're really working in this kind of gray zone. And this, I guess as clinicians, one of the things that we find difficult is working with uncertainty. But it's about developing a hypothesis and then testing out that hypothesis and seeing how people respond to it. Next slide. Resources that are available in the States. So although we're funded primarily to work with mental health services, we can always talk to anyone on the phone, and we're more than happy to kind of talk through cases on the phone if that's useful for people. We also provide education and training, and a bit like the webinar that we're delivering today, we run a series of webinars, and again, they're open to anyone. We have a limited capacity to see people outside area mental health services based on clinical need. So do feel free to call us if there's any particular issues you'd like to discuss. Next slide, thank you. And I feel a bit awkward about talking about the CDDH in Monash because Jane's here and she knows a lot more about it than I do. But that's another resource, particularly for GPs working with people with intellectual disability, again, across the state. And their website's there, and it's got their contact details at the website. Next slide, thank you. And then there's various guides out there and frameworks. So these are produced by the University of New South Wales. Next slide, thank you. And there's another one. So I'm assuming people get copies of these slides, which is why I've included those at the end. So they're resources that people can access. And there's some other websites and things that people might find useful. But essentially, that's the end of the formal presentation. So thank you for listening.
Thanks, Chad. I was wondering if you've got a little bit of time. There's a really brief amount of time just for anyone who had any questions or anything to clarify with Chad. Obviously, it's a huge topic and very complex, and we probably all face it every day with our patients in a lot of ways.
The way I think about it, it's a bit like learning to ride a bike. I can talk about it as much as you like, but you'll never be able to get the bike and ride it. It's actually about doing it, and it's that kind of usual medical apprenticeship model that works best.
Yeah. All right. If we haven't got any questions or clarifications for Chad, we might pass on to Amy for her case presentation. We are getting up to 8:30, so we do need to wrap it up. I'd really like to thank Chad and Jane and Amy for their contribution today. I'd just like to remind you of the Health Pathways, which has resources for us all to log into, a lot of them associated with what we've been talking about with this ECHO project. I'd like to acknowledge the hard work of the Spider team. I think there's a Spider there with Kerry and Nicole there, and all the hard work behind the scenes they're doing to improve the lives of people with intellectual disability in our community. Thank you, Amy, for your case study today. And if this has stimulated everyone to think of a case they might want to have a talk about in our subsequent echoes, please do, because Chad and Jane will be joining us again with their expertise to run through some stuff. So I'm sure we'd have some interesting cases to talk about. And there is, don't forget to evaluate the sessions. I think it's important feedback for the ECHO and Spider people to have that feedback in their evaluation. I'd like to invite you to join us in 2 weeks' time at 7:30, where we're going to discuss supporting and treatment for mental health for people with intellectual disability. And Chad is going to join us again along with Jane. So we're looking forward to seeing you next week. And thanks very much, everyone, for caring for this very valuable and vulnerable members of our community. And we look forward to seeing you in a couple of weeks' time. Thank you.